Uh, Dear professors, chairman, and colleagues, good afternoon. It's my great honor to give my talk here to share my knowledge with you. But before we move on to the issue, I would like to make a survey. So do you think the anti-angiogenesis treatment strategy in MCC has significantly improved the prognosis of MCC patients, and why? Do you think yes or no? Okay, I think every one of you will have your answers and have your opinions. Here, I will give my understanding about this issue. The anti-angiogenesis treatment in colorectal cancer, the ideal and the reality. I am from the first affiliated hospital of Nanjing Medical University. So I will discuss this in three parts: what, why, and how. The book, The Brief History of Humankind, gave me a lot of shock about the evolution of humankind in the past 70,000 years. Humankind survived from natural disasters, pestilence, starvation, by destroying the environment, sweeping away other primitive men, distinct millions upon millions flora and fauna. Till now, the amount of humankind has soared to 7 billion and spread all over the world. I am wondering whether in God's eyes, the humankind is a big cancer in the earth. And if someday the God wants to sweep away all the human, what is the best way? Kill the person one by one, I don't think it's a good idea. However, destroy the environment where people live in could be a high efficient way. As the Bible has mentioned, flood. So when we compare the macro world and the macro world, there are similar lessons. Angiogenesis plays a crucial role in different stages like tumor growth, development, and metastasis. The tumor will rapidly grow and metastasis when the tumor vessel formed. Feng is the first person who postulated the hypothesis about the anti-angiogenesis treatment. Because the growth of tumor is dependent on neovascularization, the tumor secretes tumor angiogenesis factor that is responsible for inducing angiogenesis. On the other hand, the angiogenesis inhibitor could directly contact with the blood vessel and targeting to the tumor neovascular. And, important, it can be used in a broad range of cancer. So, it seems that anti-angiogenesis should be a potential or even perfect strategy for treating cancer. Actually, there are several kinds of anti-angiogenesis drugs in clinical application. As we all know, the bevacizumab, Abcept, ramucirumab, and regorafenib with different targets and mechanisms, but all of them are targeted to the VEGF and VEGFR signaling. However, the anti-angiogenesis medicine didn't show exciting efficacy. As we know, the long-term or the short-term benefit has been proved in a series of clinical trials. However, the benefit was usually within 4 months and mostly around 2 months, which cannot be satisfied. So the gap between the idea and the reality is just like the little dragon maiden. The idea is just existing in our mind, but reality is what we can see. So the next question is why and how? Okay, let's see the reason behind. It is a very complicated issue, and I cannot explain them clearly, and I think nobody can explain them clearly. But I will try to give my understanding. I give 4 keywords. The first is heterogeneity, and the second is inhibition, then surrounding, and the last, resistance. We will discuss this one by one. So when we talk about the tumor vessel, we should know that tumor vessels are a group of different tumor vessels. There are at least 6 distinctly different types of blood vessel with respect to organization, structure, and function. They are different from normal blood vessels. The picture showed different kind of vessels. You can see the picture A is typical mother vessel, and B is mother vessel with intraluminal extension. C is GMP, glomeruloid microvascular proliferation. The D is vascular malformation, and E is feeder artery. The E is vascular mimicry. If we look at the picture from the scanning electron micrographs, we can find that the normal vessels are very beautiful, well organized. However, the tumor vessels are well disorganized, highly branched, and sprouting. If we take apart, see the external surface of a blood vessel, the endothelial cells are extremely thin, have abundant tiny fenestrations, and have numerous sprouts. So how do these tumor vessels formed? It can be induced by ectogenic VEGF-A or tumor-secreted VEGF-A. When the researchers injected the ectogenic VEGF-A into the ear of immunodeficient mice, and 6 vessels were generated in the ear, as we can see from the picture. The VEGF-A promotes angiogenesis by 2 distinct but interrelated processes: angiogenesis and arterial venogenesis. On the angiogenesis part, the pre-existing venules will transform to mother vessel. This is a very early tumor vessel. And after days to months, the mother vessel will transform to 3 kinds of daughter vessels. The first is GMP. Its poorly organized structure resembles renal glomeruloid microscopically. And the second is capillaries, but it will experience a period of bridged mother vessel. And the third is VEGF-independent vascular malformation. On the arterial venogenesis parts, the arterial venogenesis proceeds in parallel with angiogenesis as arteries and veins undergo extensive remodeling. As we can see from the right side, the arteries remodeled to VEGF-independent feeder arteries and draining veins. So we should know that not all tumor vessels are sensitive to anti-VEGFR. Only the early vessels, like mother vessel, GMP, and bridged mother vessels, can be sensitive. But for the rest, they don't. This picture shows higher magnification of the different types of blood vessel induced by VEGF-A and following treatment with VEGF trap or control peptide. As we can see from the picture, the mother vessels and GMPs are much larger and more frequent in control peptide, which is the left column, and less in the VEGF trap group, which is the right column. Whereas once formed, the FAs, the feeder arteries and draining veins, are not distinguishable. Interestingly, the VEGF trap profoundly affected VEGF-induced angiogenesis and arterial venogenesis, but its effectiveness was highly dependent on the time of administration. As we can see from the left column, if we treat the animal at the early time, the mother vessels and little edema in there's very few mother vessels and little edema in treated group. But if we treat the animals at the later stage after 2 months, the ear thickness, VMs, FVs, and DVs are equivalent in VEGF trap and control peptide treated mice, as we can see from the right column. So why only the early vessels are sensitive to anti-angiogenesis treatment? The very important reason, one of them, is that the early vessels strongly express VEGFR2, but for the late vessels express very little. So as we know, most of the anti-angiogenesis treatment are aiming to VEGFR2. The second reason, I think, is inhibition instead of killing. Because anti-angiogenesis, it doesn't result in the killing of all tumor cells. Residual tumor cells rendered hypoxic by a compromised blood supply are stimulated to make increased amounts of VEGF-A that may overwhelm anti-VEGFR therapy, access and stimulate new blood vessel growth, especially when accompanied by increased expression of matrix components that bind and sequester VEGF-A, protecting it from anti-VEGF drugs. To mix metaphor, wounding a bear can make him very hungry. So we can see clinically the tumors progress rapidly and more malignant when treated by VEGF-A. The third, I think, the surrounding factors. Because the tumor environment is far more complicated than what we have known. Tumor vessels is just one factor. That matrix, host cells, immunoenvironment, lymphatic vessels, and their interactions also play important roles. Let's give an example. Their study showed that collagen 4 and total collagen accumulate perivascularly during VEGF blockades. We can see from the left column IHC study. The perivascular membrane envelope was thin at day 0. However, it increased significantly at day 15 and further at day 14-4, forming a thick layer encasing the vasculature, as we indicated in the red arrow in the right column. Besides, the mesenchymal microenvironment are also very, very important. This picture was from research from PNAS. The hypoxia, low pH, and pressure will promote the abnormal angiogenesis itself and promote inflammation and induce resistance to radiotherapy, chemotherapy, and immunotherapy. And it will also induce cancer stem cell phenotype and the EMT, invasion metastasis, and the resistance to apoptosis and autophagy, and so on. So the surrounding factors are very, very important, far more than we have known. The last is resistance. Actually, the above discussed factors are also responsible for resistance. Here is the most recent review, summarized the resistance to anti-angiogenesis therapy in cancer, alteration to anti-VEGF pathways. However, it didn't show significant knowledge. The picture was extracted from this review. The alternative angiogenesis factor are listed on the right side, and phenotypical tumor changes are listed on the left side. So, the last question, how for the future direction? How to improve the efficacy of anti-angiogenesis? I think there are 4 words we can use. The first is use early. The second is combining. The third is discovering. And the last, clarifying. As we know, VEGFR inhibitor has been used in clinical application. And among them, regorafenib, fruquintinib, had shown encouraging efficacy in MCRC patients as third line. The Conquer study showed the regorafenib prolonged the overall survival, and the Fresco showed fruquintinib prolonged overall survival in third line. Whether this agent will confer more benefit if they were used in early line. Now it's under investigation, but we are hoping that the results will come soon. The second is combination. But since anti-angiogenesis itself can only inhibit instead of killing cancer cells, so it should be combined with other treatment strategy like chemo, like immunotherapy, targeted therapy, radiation, and other. Bevacizumab plus chemotherapy is better than chemotherapy alone. It has been proved in a series of clinical trials, as we all know this. And there's another interesting trials in hepatocellular carcinoma. The atezolizumab plus bevacizumab has showed significant efficacy. The objective response rate is as high as 65%, and the FDA has named this as a breakthrough therapy. And this, I think, will give some hint in other cancer types, including MCRC. So the last is clarifying mechanism about resistance and finds predictive markers for anti-angiogenesis. But unfortunately, I searched the recent reviews. I didn't find very exciting findings. We are now far from the goals to clarify all the mechanisms. Here, I have to see this slide in Chinese because it's hard to see in English. 孙子兵法上说我们要作战，要讲知己知彼，百战百胜。我最喜欢的一句话叫胜兵先胜而后求战，败兵先战而后求胜。那这都是说我们一定要搞清楚自己的对手的本质，我们搞清楚自己，我们才可能在治疗、在对抗中获胜。兵法如此，治病亦然，否则我们的治疗就可能永远是像在下一盘残棋，你总是被别人的小兵小卒逼得要命，然后自己步履维艰，如履薄冰，步步为营，最后还是死路一条。So I would like to thank my boss, Professor Shu and Professor Gu, and especially I will thank Professor O for his invitation to give me this chance to share my knowledge with you, and also thank Professor Liu for her help in this PowerPoint. Thank you all. Thank you for your attention.